Welcome to a bonus edition of Primary Care Pharmacology. This is not one of my normal videos. I'm not going to take a class of medication and talk to you about it for the next 20 minutes. Instead, this is a re-recording of a presentation I gave for our local Primary Care Education Trust on current evidence of managing hypertension in patients living with frailty. And as I'm sure you're aware, people who fit into this category aren't very well served with the current guidelines, and there's not a huge amount of research that's ever been done into managing hypertension in this group. And it's often quite difficult to work out how tightly we should control someone's blood pressure when they're reaching the later years of their life and living with significant frailty. I'm not going to be able to, unfortunately, tell you what you should be doing here. There is no one-size-fits-all answer. So what this is going to be is a review of the current evidence that we have about how to manage hypertension in this group of patients. And ultimately, you're going to have to make your own decisions, probably on a case-by-case basis. But I hope that the evidence I give you here will guide you in that, and you'll be able to feel more confident in prescribing for this group in future. So first I want to talk a bit about how the population is changing and why is this important. This is some data from the ONS about the increasing average age in the United Kingdom. And as you can see, by 2045, we're going to double our number of people people over the age of 85 living in the United Kingdom. And this is going to have a massive impact on us in primary care and in the wider NHS. This graph here represents exactly the same thing. The shaded blue areas indicating where we are now or where we were in 2020, and the lines surrounding it and where we're going to be in 2030. And you can clearly see that in those higher age groups, particularly if you're thinking about between 75 85, there's going to be a massive increase in the number of patients, and no doubt these are the people who are going to be seeing us more frequently in the coming years. Following on from that, how do we define frailty? And if you've got any interest in this, you're probably familiar with this. This is the Rockwood Frailty Scale. Whilst it's not the only frailty scale available, it's very much become the preferred frailty scale in the United Kingdom and is widely used by the geriatricians in secondary care. Now, if you're not too familiar with this, I don't expect you to go learning a 9-point scale, so I prefer to think of it in a much easier 3-point scale that we can use in general practice. This divides everyone into either mild, moderate or severe frailty, and it's entirely based around their functional status and how they're living at home. I think of people with mild frailty as people who are quite independent in managing their own home, but they may be starting to slow down. They may be starting to limit their activities on account of their health and their advancing age. People with moderate frailty, I think of as people who are needing help at home or help with personal care on a very regular basis. They usually will have family members going in at least 2 or 3 times a week, sometimes every day, to just help with bits and pieces around the house, or they may be even living with family members to provide that extra support for them. People with severe frailty are those patients who are completely dependent on other people for their personal care, be that other family members or professional carers or people living in residential facilities. Remember that it doesn't matter why you've reached this degree of dependence on other people. Equally, you could be severely frail, but physically quite fit, but on account of dementia need a lot of help with personal care, or you could be completely cognitively intact, but because of, say, degenerative joint disease, find it very difficult to look after yourself. So it's not why someone's achieved this point of functional decline; it's just the fact that they have that helps us decide how frail they are. Now, in terms of how frailty is reflected in current guidelines for managing health, it's pretty limited. The current guidelines we have available to us that do take into account frailty and mention frailty and how you might manage someone. There's a bit in the NICE CKS and multimorbidity about bisphosphonates, and unfortunately that's pretty much it. Most of the research for various topics out there has been not been conducted in patients living with frailty, and thus you can't really apply it to this group of patients, thus making it really difficult to know what to do sometimes, and you can't always just go and look at the NICE guidelines and make your choices based on it. So getting into the main topic here, managing blood pressure in older people. And first I want to consider out what blood pressure is ideal, where we have a very target-based system for blood pressure and we try and treat everyone to a certain limit. And this is important, and the evidence for reducing blood pressure in younger patients or patients who are not frail is overwhelming. We know that if you've got a higher blood pressure, you're much more likely to have heart attacks or strokes, And in terms of the preventative medicine that we do in primary care all the time, blood pressure management alongside diabetes management is probably the most powerful thing we can do. And it's certainly an important topic for all of us. Now, there's various guidelines out there about how tightly we should control blood pressure. The European Society of Cardiology is a bit more aggressive than NICE, but NICE also mentions that we should use clinical judgment for people with frailty or multimorbidity, although they don't go into much more detail with that, and they leave it very much up to us. Unfortunately, this isn't reflected in QOF, and QOF targets will be the same for pretty much all patients, regardless of how frail or how many other conditions they've got. And I think this is a bit disappointing, and I think this rigid adherence to target-based, age-based targets, regardless of a patient's wider circumstances, can actually be quite harmful. And one thing we really don't want to do when we prescribe is cause people harm. And I do think that NICE could improve this by reflecting an individual's frailty when determining a target. And I'm certainly I do make heavy use of the of coding patients that they're not appropriate for greater blood pressure control if I don't think it's the right thing for them. Now, we know that blood pressure changes with age, and that's primarily due to increased arterial stiffness as those blood vessel walls become full of atheromatous plaques and the endothelial linings change. And it's also got something to do with our lack of ability to maintain our blood pressure, regulate our blood pressure in changing conditions for our body, leading to those big fluctuations in blood pressures we see in huge postural drops we can see in older people. We also know that blood pressure tends to decline in the final decade of life, much more so if you're living with dementia or frailty, and in the last year or two of life, it tends to decline quite precipitously. So, getting on to the evidence here, and I'm going to present this in terms of the evidence we've got that we should be aggressively treating blood pressure and the evidence we've got that we should be a bit more restrained and a bit more lax about blood pressure targets. And I'm going to start off with the earlier evidence we had that favoured more aggressive blood pressure strategies in older patients. Here's one of those key trials that has come to define our current practice. This is the HIVET trial, which was published in the New England Journal back in 2008. This is a randomised control trial looking at patients over the age of 80 and randomising to either a target blood pressure of below 150 over 90 using indapamide and or perindopril, or letting their blood pressure go over 160. And the results were pretty concrete there. There were a huge reduction in the rate of stroke or heart failure or cardiovascular deaths or all-cause mortality in patients who were treated for their blood pressure. And this led to a widespread belief that no matter what a patient's age is, it's very important that you do try and bring down their blood pressure. However, there's some problems with this study, and there's some reasons why we can't necessarily apply it to everybody. This is here buried in the methods, and it's talking about the exclusion criteria. And if you look at the last bit of this paragraph I've highlighted, you can see that they wouldn't include any person who has a diagnosis of dementia or requirement of nursing care. And thinking about our patients living with moderate or severe frailty, this describes an awful lot of them. And then can we really be applying these findings to all those patients? Something else I'd like to highlight here about the methods is the median duration of follow-up was only about one and a half, 2 years. So this doesn't really give us much information about how tighter blood pressure control affects people in the long term. This was another study published a little bit later in 2015. This was the SPRINT trial, and this was randomized. This randomized people to either aggressive blood pressure targets, that is a below 120 systolic, or what they called standard blood pressure targets below 140. And here they found quite a significant reduction in the rate of cardiovascular death or all-cause mortality in patients who are aggressively treated for their blood pressure. Now, of course, this is patients over 50 years. So this isn't necessarily encompassing all those patients who we would think about as being frail. But when they reanalyzed the same data, and this time they only looked at the over 75s, they pretty much found the same thing, that aggressive blood pressure control seemed to be associated with reduction in cardiovascular and all-cause mortality. Now, the problem with SPRINT is they were very selective in the patients they chose. And I'd like to highlight this here again, that they excluded anybody with a medical condition likely to limit survival to less than 3 years. And I think about all my patients that I would call moderately or severely frail, and I think it would be entirely unbelievable that any of them had a prognosis of 3 years or less. So again, you probably can't apply these results to all people living over the age of 75. In fact, their criteria is so strict that probably only about a third of Americans who are over 75 would have actually qualified for SPRINT in the first place. But what this does tell us is there certainly are a group of people out there that probably do benefit from tight blood pressure control. It just doesn't help us work out who they are. So that was the evidence for why we should be aiming for tighter blood pressure control in older people. Now let's look at the evidence for why we shouldn't. And the first couple of papers I want to talk about were either replicating SPRINT or looking at the same data set that the SPRINT authors based their findings on. And the first one I want to mention is a study based on some population data from Ireland. And they looked at a group of patients who would have qualified for SPRINT, and they looked at how blood pressure affected their rate of falls and syncope. And they found those patients, again, who would have qualified for SPRINT, who would have met those stringent inclusion-exclusion criteria, blood pressure, an average systolic blood pressure of below 120 seemed to be associated with a massive increase in their risk of injurious falls and syncope. Here's a similar paper from 2021, this time looking at the original data from SPRINT and focusing on the time it would take for an intensive blood pressure target to give a patient both benefit but also the time it would take for them to come to harm. And they produced these two graphs here, and they're quite illustrative in the stark differences between these two numbers. So the panel on the right is the time to come to harm. And as you can see, the two lines represent the two groups there, the intensive or standard blood pressure treatment group. And the point at which they seem to diverge is around about the 3-month line, where you start seeing significantly increased risk of serious adverse events or emergency department attendances as a result of blood pressure. The graph on the left shows the time to benefit, the time at which point those cardiovascular benefits associated with tighter blood pressure control become apparent, and that takes around about a year before the two lines seem to diverge. What this does tell us is that if a patient has a realistic prognosis of potentially around about a year, there's really very little benefit and probably harm would come from tightly controlling their blood pressure. Any benefit you might achieve is not going to be apparent within their lifetime, but you certainly could put them at greater risk of falls and syncope in that last year of life, obviously something you'd like to avoid. The next paper I want to show you is this paper here from Age and Aging. And I think this is a good paper here because it highlights the effect of frailty in all of this. Very simply, this paper looked at how a patient's frailty level influences their outcomes and influences the effect of blood pressure. And you can drill it down to this simple message that in non-frail patients, a systolic blood pressure below 140 did seem to reduce their risk of all-cause mortality. But if you looked at the same group of patients, same age group of patients, but those living with frailty, it didn't seem to make a difference at all as to whether their blood pressure was below or above 140 in terms of their longer-term mortality. Another really interesting paper that looked at the effect of frailty on blood pressure and survival is this one here, another paper from Age and Aging. And this was really interesting because this was based on UK primary care data. And in total, they took about 416,000 patients, and they included pretty much anyone who was over the age of 75 and had a few blood pressure readings on their primary care record. They found that patients over the age of 75 having a blood pressure below 130 actually seemed to increase your mortality than those patients versus those patients with a blood pressure of 130 to 140. And in patients who are over the age of 75 but living with moderate or severe frailty, high blood pressure was not at all associated with increased risk of mortality. They gave us a couple of graphs which highlights this in a really interesting way. The first of which I'm going to show you is for patients between the ages of 75 and 84. And each dot represents a hazard ratio for all-cause mortality relative to a blood pressure of 130 to 139 systolic. So that group there, 100 to 139, is the reference point. If the dot is on the left-hand side of the dotted line, it implies a reduced risk of all-cause mortality. If it's on the right-hand side of the dotted line, it implies an increased risk of all-cause mortality. And again, each blood pressure group has been divided into patients who aren't frail, living with mild or moderate/severe frailty. And as you can see here, in all patients, regardless of their degree of frailty, a blood pressure of 140 to 160 seemed to be associated with a reduction in the risk of all-cause mortality, whereas tighter blood pressure control, that is below 130, seems to be associated with a very increased risk. And there seems to be this sort of sweet spot between around the 140 to 160 systolic region where you achieve the lowest point of mortality or lowest risk of mortality in this age group. And this is even more pronounced if you're living with frailty. The next graph, again, exactly the same structure, but this time showing patients over the age of 85. And what's really interesting here is, as you can see, that even amongst patients who aren't living with frailty, those over 85 seem to have a reduced risk of mortality with a blood pressure of over 180 systolic than they do with a blood pressure of 130 to 139. This, of course, is completely contradictory to what we've read from Hyvet and Sprint, and it really just turned things on its head a little bit. Now, as I mentioned earlier, this is based over a huge number of people, and it doesn't take into account each patient's individual risk factors. But I hope that it illustrates is that when you look at wide population data, in patients, particularly those patients living over the age of 85, lower blood pressure at seems to be worse for them and lead to increased risk of death at a younger age. This is another paper, this time based on some patients living in Berlin in Germany, and it illustrates much the same thing. Patients who are over the age of 70 but with a blood pressure below 140 over 90 on average do seem to have an increased risk of all-cause mortality, but this is mainly those patients with a systolic blood pressure of less than 130. Again, completely contradictory to what Sprint told us. Thinking about Sprint, there was another really interesting finding from this paper that I'd like to highlight, and that was regarding patients over the age of 80 who had a previous cardiovascular event. So that group of patients who we think of as being a higher risk for further major cardiovascular events in future and might benefit from tighter blood pressure control, found completely the opposite. Those with a blood pressure of below 140 over 90 in this study had a massive 61% increase in their risk of all-cause mortality compared to those with more relaxed blood pressure targets. This is, again, completely contradictory what we learned from Hyver and Sprint, and really does have to make us think about how we control blood pressure in this group of people, because the data just doesn't point us in any one particular direction. Now, you may be thinking that I told you earlier on that we know that blood pressure seems to decline in the final years of life, and maybe this decline in blood pressure or this increased mortality in those with lower blood pressure is simply representing that those patients are just reaching the last years of their life anyway. So the authors went away and reanalyzed the data, and they tried to account for it, and they pretty much found the same thing, that even when you factor this in, the same associations are once again seen. They drew us this very helpful graph here, and again it's looking at hazard ratios for all-cause mortality with a reference point of about 140. And as you can see, there's a U-shaped curve there, and I hope you can appreciate it, that below the horizontal dotted line, that suggests a reduced hazard ratio, reduced risk of all-cause mortality rate related in reference to a blood pressure of 140. And as you can see there, that the lowest point of that U-shaped curve seems to be sitting around the 160 region, and maybe that is the ideal blood pressure for a group in patients over the age of 75. Another paper here, this one from Milan, again looking at patients over the age of 75 and trying to work out what their ideal blood pressure is. And this graph shows as much the same thing as the previous paper, with a reference point here, a reference blood pressure of 160 to 180 systolic and a diastolic of 90 to 100. The different lines, the different bars on the graph indicate the hazard ratio for 10-year mortality, with the bars of which have a star above them, those that reach statistical significance. As you can see here, once again, those patients with a blood pressure of below 140 systolic and particularly below 120 systolic seem to have an increased risk for all-cause mortality than those with a higher systolic blood pressure, in this case 160 to 179. When they dug into the data a bit more, they again found a U-shaped curve when comparing mortality with systolic blood pressure, and finding that low point, that ideal point, sitting around 165 systolic. That was a fairly deep dive into the current evidence of prescribing for hypertension in older patients and those living with frailty. But clearly there's an awful lot here that we just don't know. And unfortunately, I can't give you a definite answer of what you need to do and what you should be doing in your day-to-day practice. And we're going to have to take each patient in a case-by-case basis and make a decision about what's right for them. Now, one thing I should highlight is that there haven't been any randomized control trials studying the use of antihypertensive in those living with frailty. The only randomized control trials I've presented to you today were Hyvet and Sprint at the beginning of this talk. And as I mentioned at the time, neither of those studies included patients that we would consider as being moderate or severely frail. Clearly, there's a need for further research here, and I'd be very much interested if anyone has got any data, randomized controlled trial data, specifically including patients living with frailty. What we do seem to know is that some patients do have a cardiovascular benefit from blood pressure reduction, but others don't, and others come to harm as a result of that. And how do we decide who will benefit and who won't? I think probably every single person living over the age of 70 probably has their own ideal blood pressure, but we don't have any way right now of defining exactly what this is. Clearly, a generalized target-based approach is simply entirely based on someone's age is not the right way to go, and I would discourage you from just blindly trying to reduce all patients' blood pressures below a certain level, regardless of their wider circumstances. This is certainly going to be something of great interest in the future, and I do hope that one day we'll be able to easily calculate a patient's ideal blood pressure and tailor design their treatment directly to that. Unfortunately, we're just not quite there yet. Another interesting thing is that the data is fairly conclusive that if you control high blood pressure in middle age, you reduce someone's risk of frailty and dementia in the long term, which of course makes a lot of sense, as you're probably going to reduce that small vessel disease burden in their brain, which we know is associated with functional decline later in life. But at some point, the balance probably tips, and you want to start being a bit more permissive about letting someone's blood pressure rise. Where is that point? At what age should we start letting someone's blood pressure rise? Of course, it's probably not the same for everybody, and it depends on a lot of personal circumstances, a lot of personal factors for that patient, and everyone's going to have their own ideal. So, how do you then go and take what I've told you today and put this into practice in your day-to-day clinics? And there's lots of guidelines out there for blood pressure, but the one I particularly like is from Canada, because it's the only blood pressure guideline that specifically gives targets for patients living with frailty. And they suggest in frail patients, a general target of about 140 to 160, which seems reasonable, and those who are severely frail, saying 160 to 190. What I tend to do is I tend to avoid a blood pressure of below 130 in patients over the age of 75, unless I've got a really specific indicator that that person needs a tighter blood pressure than the other patients of that age group, in which case I might aim a little bit tighter. In patients living with moderate or severe frailty, I tend to avoid blood pressure targets altogether, again, unless there's a really clear need for them to have a lower blood pressure than where they would normally sit. And I very much do this on a case-by-case basis. But I find a lot of the time I find myself taking blood pressure drugs away from this group of patients, telling them to put their blood pressure machine in the cupboard and not bother checking it again. And I hope that I'm doing the right thing in doing so. This concludes this talk about hypertension and frailty. I apologise if you came here today hoping that I was going to give you a definite answer about what you should be doing. The truth is we just don't know. Probably already you are making these decisions on a case-by-case basis for your patients, and I'd encourage you to keep on doing so. I'm very keen to hear any thoughts, and if you've got any interesting research that I've overlooked here that might change the outcome of this talk, so please do get in contact either by commenting on the video or using this email here. I do hope to get my next video out about beta blockers to you soon, so please do bear with me. I do this all in my own free time, and it's sometimes quite difficult to find the time in the day to do this. Many thanks once again for watching. Bye-bye.